Welcome to the Pancreatic Cancer Action Network's webinar, a multidisciplinary approach to pancreatic cancer. My name is Sheila Bott, and I am the Senior Case Manager of HCP Services for the organization. At the Pancreatic Cancer Action Network, our goal is to provide comprehensive resources to make informed decisions. Patient Central can provide free, personalized information on many topics, including pancreatic cancer specialists and treatment options. Contact Patient Central at 877-2-PANCAN or email patientcentral@pancan.org. I would like to take this opportunity to thank our webinar sponsor, Ipsen, and to thank our scientific and medical affairs industry members, AngioDynamics, Halozyme, Ipsen, Janssen Oncology, TriSalus, and TYME. The webinar is scheduled for 60 minutes and includes a presentation followed by a Q&A session, time permitting. The questions that are relevant to today's topic and more general in nature will be prioritized. A recording of this presentation and the slides will be available under the Educational Events page at pancan.org. Now I would like to introduce our presenters. All three presenters are from the University of Miami Sylvester Comprehensive Cancer Center in Miami, Florida. Dr. Peter Hosein is an oncologist and clinical researcher. He has been the principal investigator for multiple phase 1 and 2 clinical trials for patients with liver and pancreatic cancers. Dr. Daniel Sussman is a gastroenterologist, and he co-manages a multidisciplinary gastrointestinal cancer prevention clinic in collaboration with the genetics department. Dr. Nipun Merchant is a surgeon and associate director of translational research. He is also a member of the Scientific and Medical Advisory Board for PanCan. Dr. Merchant, I will now turn the presentation over to you.
Well, thank you. Good afternoon, everybody. On behalf of Drs. Sussman, Hosein, and myself, we'd like to welcome you to this webinar. We're going to discuss multidisciplinary management of pancreatic cancer. So we thought that instead of just kind of giving you a talk about pancreas cancer in general, that we would give you some facts and figures and then present some cases how patients actually present with this disease so that you have an understanding of how patients present and how we would work them up and treat them. So we'll start with a little bit of introduction about the pancreas and pancreas cancer, and then we'll talk about patients that present with localized disease that's confined just to the pancreas, how would we work them up, and how would we treat them. And then we'll move on to patients that present with advanced disease that has spread to other areas, and some of the way and novel ways that we treat them now and understand how their tumors may respond to treatments. And then we'll end with a little bit of discussion about familial pancreas cancer and how we would screen high-risk individuals. So just a little bit of background on the pancreas itself. The pancreas is an organ that sits in the back of the abdomen. It sits behind the stomach, shown over here. The stomach is right here. And the pancreas has several functions. Primarily, it produces enzymes that help with digestions of proteins and fats that's produced in the pancreas, and then it drains through this duct here, that green thing shown here, and then drains here into the first part of the intestine. So when food comes out of the stomach, the enzymes start digesting the fats and proteins. Something that all of you may be more familiar with is that the pancreas actually produces insulin also, which helps control glucose levels. So in diabetics, it's the lack of control of insulin and glucose that makes people diabetics, and that's somewhat of the function of the pancreas. So pancreatic cancer, like most other cancers, begins as normal cells start growing more rapidly, and with genetic mutations start growing even more rapidly. And you need several mutations that have to occur over long periods of time that eventually form cancer, and that could be a 10 to 20 year period sometimes. Almost all of the pancreas cancers you hear about are made from the exocrine cells, cells that produce the enzymes to help digest fats and proteins. And that's the most common type of pancreatic cancer, called pancreatic ductal adenocarcinoma. And when when people hear about pancreas cancer, that's generally the type of cancer we're talking about. A more rare form of pancreas cancer that occurs in only about 5% of people are neuroendocrine tumors, and these originate from the cells that produce the hormones in the pancreas, the insulin and other hormones. These tumors are much less common, but they're also much more indolent, meaning they're not as aggressive as the adenocarcinoma type of the pancreas. So some of you may be familiar with this, but pancreas cancer is one of the few cancers that incidence continues to rise. Just last year, it became the third leading cause of cancer death in the country, and within the next 2 to 5 years, it will likely overtake and become the second leading cause of cancer death in this country, just behind lung cancer. So a lot of patients come in and ask, well, how did I get this, or why did I get pancreas cancer? I live a healthy life and I still have it. In general, we really still don't know what causes pancreas cancer in the majority of cases, but we do know that there are certain risk factors that increase the incidence of developing pancreas cancer in patients. And some of the risk factors that are completely under the control of an individual include cigarette smoking. We do know that people who smoke are at 2 to 3 times higher risk than people who don't smoke. And about a third of all pancreas cancers that we see in patients have a history of smoking, and this includes cigars and smokeless tobacco also. Obesity is another risk factor. So obese people have a much higher likelihood of developing pancreas cancer compared to people who are non-obese. And other factors like diet and alcohol have also been implicated and can be controlled by the patient. Other risk factors that generally can't be controlled include a family history. So there is a component of family history, but this is still a minority of pancreas cancers, probably less than 5%. That if you have a strong family history of first-degree relatives that have pancreas cancer, you're at higher risk of developing pancreas cancer. Diabetes is an interesting topic. In general, there's 2 onsets of diabetes, as a juvenile or adult onset diabetes or type 2 diabetes, which occurs primarily in people that are in their 40s and 50s. If an older person, 70s, 80s, develops new onset diabetes, it's not regular diabetes, and you really have to start thinking about somebody who has pancreas cancer and work them up for that. This type of link, we haven't really been able to understand fully why this occurs, but there's a lot of ongoing research about the link between diabetes and pancreas cancer. Chronic pancreatitis is also a risk factor for pancreatic cancer, generally in people that have been alcoholics for a long time, have had repeated bouts of pancreatitis. There's some genetic components to this also that we'll talk about later on. So we're going to get started with a case presentation of a patient that presented with localized pancreas cancer and how they would present. And I'm going to turn this over to Dr. Peter Hosein.
So this is a real patient who we saw here at our center a couple of years ago, 65 years old. He was a smoker and had unintentional weight loss, which is a very common presentation. Also, we see very commonly patients complaining about indigestion, and many times they treated themselves with over-the-counter treatments, or they even sometimes go to a gastroenterologist, but because pancreas cancer is not that common, this is not the first thing that you think about. So that was not really followed up on until he developed dark urine and yellow color of the eyes, which we of course refer to as jaundice. So at that point, he had laboratory tests done, and these tests here, the first few tests are related to the liver function, and the bilirubin level is, bilirubin is something that the liver produces that should be excreted efficiently, and the level should be around 1 or less, and this patient's bilirubin level was 8, so that backs up into the bloodstream, and that's what causes patients to turn yellow. And the liver enzymes are elevated as well. These are above the normal range. There's a tumor marker level, a protein that we can test in the blood called the CA19-9 level, which we'll talk about in a minute, which is also elevated. So this combination of factors really raises the suspicion significantly for pancreatic cancer. So, Nipun, can you talk about the anatomy and why this type of tumor causes the bilirubin level to go up?
Yeah, so we just want to give you a quick anatomy instruction on the pancreas because it's very important to understand how to manage patients that come in with pancreatic cancer. So this is a picture again of the pancreas. It would be sitting behind the stomach. The stomach's been taken away here so you can see the pancreas here. The stomach hooks up here to the first part of the intestine. And the liver is up here. As Dr. Hosein implied, the liver produces bile. Bile helps you digest fats. That's produced in the liver, and it drains through these two ducts, these two green things here, and it gets stored here in the gallbladder. So when you eat food, the food goes to the stomach sends a signal to the gallbladder squeezes, and this bile comes out through this green duct that actually goes through the pancreas here and drains into the intestine. So when the food comes here, the bile helps digest the fats. Now it's the bile in your intestines that actually make your stool turn brown. So if you have a tumor over here, something that's blocking the bile duct, and the bile can't drain through this bile duct into the intestine, several things happen. One is since there's no bile in the intestine, the stool turns very light in color. And then since the bile can't drain here, the bile backs up into the liver, and when it's backed up into the liver, it gets absorbed into the bloodstream. The blood filters through the kidneys, and your urine turns very dark in color, and your skin turns yellow. So when we talk and look at how tumors are in the pancreas, there's very important things that we need to see. These red and blue things are some of the major things. These are major blood vessels. This blue blood vessel right here supplies 3/4 of the blood to the liver. This red one right here supplies blood to 3/4 of the intestine. And this red one right here supplies the rest of the blood to the liver. These are all very important blood vessels that you can't live without. And tumors in this area of the pancreas, a lot of times if they're involving these blood vessels, if we try to go in and take the tumor out from here and we just kind of scrape it off these blood vessels, when we do surgery, we have to take out 100% of this cancer. Even going in and trying to take out 98, 99% of the cancer is as good as not doing the operation. So when it involves these blood vessels, we can't just go in and take these blood vessels out, which will be important as we talk about working up these patients. And I'll talk a little bit more in detail about some of the things that we can do to try to overcome some of these limitations.
So as was mentioned, one of the most common presenting signs or symptoms with pancreatic cancer is jaundice or yellowing of the eyes or skin. And that's frequently a sign that the head of the pancreas has been involved as the source of the pancreatic tumor. There's a procedure with a long name that's shortened and abbreviated is known as an ERCP, and that basically is a type of endoscopy, which is a flexible tube with a camera on the end of it that gets passed through the mouth, through the esophagus, down through the stomach, and into the second portion of the small intestine. That allows us to access the door through which the pancreas duct and the bile duct dump their digestive juices into the small intestine. If a patient presents with yellowing of their eyes or skin and they do end up having a pancreatic head mass, this mass can sometimes block the bile duct. And we can take advantage of that fact by using this procedure known as an ERCP to access these digestive ducts, to pass some catheters and instrumentation through these ducts minimally invasively. Sometimes we're able to sample tissue to try to help with a diagnosis, and frequently we're also able to provide some anatomy by injecting some contrast material through the ends of these ducts, and we're even able to help alleviate some of the symptoms and signs of the obstruction that happens from a pancreatic head mass. On the next slide here, we'll actually see that once these instruments, these endoscopes are passed down into the small intestine, we have the ability to pass these catheters into the opening of these ducts into the small intestine itself. And in this case, we can see that there's a mass or a growth in the head of the pancreas. And this mass or growth in the head of the pancreas is blocking the bile duct. One of these catheters that can be passed through the instrument can be used to place or deploy a stent. A stent is a tubular-shaped structure that can open up to alleviate an obstruction, kind of like what a plumber might do at your house if you have a blockage in your plumbing. And this allows the bile to flow freely through the bile ducts, through the mass in the head of the pancreas, and on out into the small intestine the way it normally does with normal intact anatomy. This helps the jaundice to disappear and allows that yellow color to disappear from the eyes, skin, and from the urine so that patients have symptomatic relief. Our picture on the right here is a view of one of the images we see at ERCP, where there's a mass present here in the head of the pancreas, and during this procedure, eventually, the stent placement allows the better flow of these pancreatic and biliary juices so the patient has fewer symptoms. There's a related procedure known as an endoscopic ultrasound, abbreviated as EUS, and this is quite a versatile procedure. Again, it's a type of endoscopy, so patients receive medication to help them sleep, and a camera and an ultrasound probe on the end of a flexible tube are passed through the mouth, down into the stomach and into the small intestine. And this procedure actually has multiple potential purposes. The ultrasound probe can be turned on so that the pancreas and the bile ducts in the liver can be visualized through the wall of the stomach itself, and it creates an image of the pancreas itself and the neighboring blood vessels so that we can actually get a better delineation of the size of a tumor and if there's any invasion of the tumor into neighboring structures. To translate that, this procedure, the endoscopic ultrasound, is of paramount importance in staging the tumor itself, so it can tell not just the size and local invasion, but it can help identify if there's any lymph nodes nearby that are abnormal. Lymph nodes are sometimes locations for spread of pancreas tumors. And then sometimes these pancreatic tumors like to invade local structures as well, and we can see if the tumor is invading local blood vessels. And the invasion of local blood vessels is a very important prognostic sign that helps us tell whether patients are good candidates for surgical interventions. Most importantly, this procedure not only allows staging with just taking these images by ultrasound, but biopsy can actually be performed. And by passing a needle through the instrument and into the mass itself, or the lesion within the pancreatic head itself, we can actually obtain diagnosis to try and confirm whether or not there's a cancer that's present. And this is important in determining further course, whether there be chemotherapy or plans for surgical intervention. And finally, if a patient is having some intractable pain from having a pancreatic cancer, some of the local nerves can be visualized with this procedure, and alcohol can be injected into the nerves neighboring the pancreas to try and alleviate or improve patients' abdominal pain and abdominal discomfort.
We're going to talk a little bit now about workup with what the most important test that we need, and that's a CAT scan. This is really the workhorse of how we diagnose and determine planning in terms of treatment for these patients. Many times patients come into the ER or have some vague symptoms and they get a CAT scan that's done in the emergency room, and that's a pretty general CAT scan, which usually is not adequate to really map out the detail of what we need to see when we're planning out management and surgery for patients. There's a specific pancreatic protocol CAT scan, which really highlights the timing of IV contrast and oral contrast that delineates the tumor from the surrounding blood vessels and other organs that helps us really understand what's going on. So it'll detect where the tumor is, the size and location of it, whether it's spread to other areas, namely the liver or the lining of the abdomen, and it gives us a very good sense of the relationship of the tumor to the surrounding blood vessels, and then it helps guide for surgery, radiation therapy, and if the patient is responding or not. Many times people think we need a PET scan. We do use it occasionally, but in general, a PET scan is not very helpful in terms of management of the patient initially. It helps us identify, a PET scan will light up areas that could be potentially tumor, and it will help us show if the cancer is spread in other areas. As in this example, you can see it's localized just here to the pancreas. But in general, if we have a very good quality pancreas protocol CT scan, we don't necessarily need a PET scan for planning of management. The other thing that we look at very carefully is a CA19-9 level. This is a tumor marker for pancreatic cancer, but it's not very specific for pancreas cancer. And there could be situations where patients have widespread cancer and the tumor marker could be normal, or this could be elevated for other reasons other than cancer. Even jaundice in and of itself can cause this level to go up. So it's not a very specific marker, but we do use it almost in every patient just to understand what's going on. And what we're trying to look at are trends and how these levels go during treatment. So if it's elevated before surgery and it comes down to normal after surgery and during treatment, we're happy because this clearly showed that when somebody had cancer, it was elevated and came down to normal after surgery and treatment. If it starts going up, then we start worrying again if the cancer is coming back or not. So it's a good test if it's elevated at the time of diagnosis and comes down to normal after chemotherapy or surgery. So we use this routinely to kind of assess how the treatment is going, but it's not 100% specific all the time. So coming back to our patient that Dr. Hosein had presented, he had a tumor here in the head of the pancreas, and I want to show this to show the level of detail that we can see here. This is in the head of the pancreas. These are those blood vessels that we talked about, the superior mesenteric vein right here and the superior mesenteric artery right here. And these are the important blood vessels. Many times tumors come in and are involving these blood vessels, and in that situation, there's no way we can go in and get 100% of this cancer out. But if you look at this situation here, this white thing here is the stent that's in the bile duct. But here's the tumor, and you can see a nice fat plane between the tumor here and this blood vessel right here and this blood vessel right here. And when we see this, we're happy because we know if we take this patient to the operating room, there's a very, very high likelihood that we'll get 100% of this cancer out and have negative margins of resection. So this is the type of anatomic detail that we get with a CAT scan that we're looking for very carefully before planning for surgery. So many of you may have heard about the Whipple procedure. So the pancreas is broken down into the head of the pancreas, the body of the pancreas, and the tail of the pancreas. And 2/3 of tumors that occur in the pancreas occur in the head of the pancreas here. So the surgery to do this, a Whipple procedure, what that usually involves is cutting the end of the stomach here. Sometimes half of the stomach is taken, but usually here we just take this first part of the intestine, cut it here, and cut it here at the end. We cut the pancreas right around the level of these blood vessels here, and we cut the bile duct from the liver, and we take the gallbladder. And all of this comes out in one piece. There's no way to separate out this first part of the intestine and the head of the pancreas and the bile duct. It's all attached together, so it all has to come out in one piece like this. And once this is out, to get all of the tumor out, away from all these major blood vessels, the intestines that are down here, we take them and we bring them back up here. We hook them back up to the pancreas, so the enzymes and things that the pancreas produces drain into the intestine. We hook them up here to the bile duct, so the bile coming from the liver drains back into the intestine. And then we hook it up here to the stomach. So when food comes down, the stomach will then go down. The pancreatic juices in the bile will continue to digest the fats and proteins. So this is somewhat of a complicated procedure and important to be done in centers that do a lot of these because the outcomes are really related to, better outcomes are related to centers that do high volumes of these procedures.
So thanks, Nipun. Getting back to the patient that we started talking about. So this patient had localized pancreatic cancer proven by biopsy, and according to the scan, it looks like he was a good candidate for surgery, so he was taken to surgery, and the outcome appeared to be successful. The tumor was 1.8 centimeters in size, and very importantly, all the margins were negative, meaning that we don't think that there was any cancer left behind around the tumor itself. We routinely take out as many lymph nodes as possible around the head of the pancreas in this operation, and there were 22 lymph nodes found in the specimen that Dr. Merchant showed, and they were all negative for cancer, meaning that the tumor didn't start leaving the pancreas yet. So this is stage 2 disease. And you might say, well, this is a successful operation. Maybe everything is removed. Are we finished? So the answer is no. The treatment of localized pancreas cancer, even though it looks localized on a scan, doesn't only involve surgery. There has to be some chemotherapy involved. It's a package of chemotherapy and surgery right now. And in a situation like this, it's accepted to do surgery first and chemotherapy after. More and more now, we're doing chemotherapy up front, but there's still a package of chemotherapy and surgery. So the patient was referred to us to oncology a few weeks after surgery, and it was at that point we had to talk about the chemotherapy options. So I'm not going to go into great detail about the chemotherapy, but the message is that chemotherapy improves survival after surgery or even before surgery for pancreas cancer. And this is a very simple figure showing what happens if you have surgery and you don't have chemotherapy. The survival could be up to 2 years on average, although there are some outliers. There are some patients who never receive chemotherapy and still have a long survival. But if you add chemotherapy postoperatively, the oldest chemotherapy we had was gemcitabine. That will improve survival on average by a few months. And then if you go up to 2 medications, gemcitabine plus capecitabine, which is an oral medication, that can push the survival a little bit longer on average. And then more recently, in 2018, we found out that a triplet combination of chemotherapy called modified FOLFIRINOX, given for 6 months after surgery, the average survival in that study was close to 5 years. So this was better than any other survival number that we were seeing before. Of course, with more chemotherapy drugs, you see more side effects. So not every patient would be a candidate to receive 6 months of FOLFIRINOX after surgery. And if patients are fit, we offer that. But if we think that the patients are older and they may not be able to handle that, then we use some of the other options. But we always try to give chemotherapy. Even if it takes the patient 2 months to recover from surgery, we still recommend chemotherapy. The idea is that if you can get through some, it's better than none. So talking about preoperative chemotherapy versus postoperative chemotherapy, we know that the standard right now for tumors which are localized, like the one we showed, is surgery first and then chemotherapy afterwards. But there are increasing number of studies looking at preoperative chemotherapy showing benefits. And what we know so far is that preoperative chemotherapy is definitely better tolerated than postoperative chemotherapy. And there may be some other advantages in terms of survival and also monitoring the response to treatment that can give us an idea of prognosis later on. And there's some situations, as we're going to show now, where we always recommend chemotherapy up front, and that is in tumors which are a little more advanced. For example, tumors which are referred to as borderline resectable tumors. So I'm going to hand it back to Nipun to talk about that situation.
So we talked about the situation where the tumor is away from the blood vessels, and we're very confident that if we take the patient to the operating room, we'll be able to get all of the cancer out. But this is a situation here where here's the tumor in the head of the pancreas, here's the stent that you see over here, and here's the blood vessel, the vein and the artery here, and you can see the tumor encroaches right up to the level of the artery and the vein. Here, again, the artery is here, here's the tumor kind of going right there. So in this situation, if we take a patient to the operating room, and if I try to just scrape it off the blood vessel here, which we can do, there's a high likelihood we're going to leave cancer cells behind. So these are the patients that we don't want to take right up front to the operating room. And because, as Dr. Hosein said, our chemotherapy has gotten so much better for pancreas cancer, and what we're finding is that these patients, if we actually give the chemotherapy before the surgery, then the tumor responds and shrinks to the point where potentially it comes off these blood vessels, and there's a much higher likelihood that we get 100% of the cancer out instead of leaving cancer cells behind. So here's an example of that situation. This is a 45-year-old gentleman who came in with back pain, which is not uncommon because, as I said, the pancreas is an organ that sits in the back of the abdomen, just a little bit in front of the spine, which is right here. So here is one of the major blood vessels, the vein over here, the artery here, and you can see his tumor is over here. and it involves a big segment of the pancreas and these blood vessels. And this is a patient that we would never take to the operating room up front because there's no way we would get all of the cancer out if we tried to take him to the operating room. So this is a patient that got the chemotherapy. He got FOLFIRINOX for 10 cycles, which is 5 months up front. And he also got some radiation therapy. And his CA19-9, which was over 1,200 when he started, came down to completely normal. Less than 37 or 39 is normal. So you can see we're very happy with this because it suggests that we have a very good response. And that's exactly what we see on his CAT scan after the chemotherapy. Here you had a big tumor over here. You couldn't even see the rest of the blood vessel. And now you see the tumor has really shrunk significantly in size. And we can see the blood vessel here. There's a little bit of soft tissue over here next to the blood vessel, but very little. The vein also, which you couldn't see before, now you see almost completely. And here this artery seems almost completely free of the tumor. So clearly a very good response to the chemotherapy. And we took this person to do a pretty complicated operation. This is this is the tumor over here involving these blood vessels initially. And basically we took some of the blood vessels here, which we can in certain circumstances, and we can also try to reconstruct, especially the vein over here in the back if it's involved. This is done in very specialized centers, a handful of centers in the country, where we'll actually take a part of the vein if we have to, take it out, either fix it primarily or use the internal jugular vein to replace that segment. So this is the operation we did, taking out this blood vessel, which we could, and then reconstructing his vein and taking the pancreas all from here and taking this whole part of the pancreas away. And if you look at his pathologic response here, when we took the tumor out, there was really no cancer in the specimen, meaning that the chemotherapy has killed all the cancer cells. The margins were all negative. All his lymph nodes were negative. And this is a person that without getting the chemo up front, he had no hopes for a cure because we would never have been able to get all the cancer out. And with the improvements in chemotherapy we see now, we see these type of responses on occasion.
Okay, thanks, Ipsen. So now we're going to switch gears and move on to patients who have metastatic pancreatic cancer, which means that when they are diagnosed or at some point during the course, the disease has left the pancreas and gone to a different organ, which most commonly is the liver. So this is a real patient recently treated here at our center, 66 years old. He had abdominal pain, went to the emergency room, had a CT scan performed, and you don't need to be a radiologist to see here that there's a large abnormality within the body of the pancreas that I'm showing you with this arrow here. And within the liver, there's some dark areas here which represent cancer in the liver. So this is his first CT scan ever performed, and we are already seeing pancreatic tumor which spread to the liver. And a biopsy was performed and it confirmed adenocarcinoma of the pancreas spread to the liver. His initial CA19-9 level was very high at 10,000. So he was in relatively good shape, and we decided that chemotherapy would be the best option. We offered chemotherapy. But before we get there, I wanted to embrace the topic here, which is multidisciplinary management. And even though most patients, when they come to see the oncologist is the face of the franchise, really, where they're doing most of the heavy lifting, but it's really a team. When a patient comes to see me, there's a big team of people behind me helping with the management of these patients. So it is often complicated, where patients have a lot of pain. Weight loss is sometimes difficult to manage. Psychosocial support is often required. So we have patients routinely see specialists from pain management, palliative care. We have specialized oncology dietitians, gastroenterologists, and dietitians go work hand in hand to help with pancreatic enzyme replacement therapy. So the digestive enzymes which are blocked from coming out because of the tumor, we can replace that with a pill that can help with digestion and help patients to maintain their weight. Sometimes we need appetite stimulants. So these are the specialties that we usually get involved very early on. So it's not just chemotherapy, but we sort of do a multi-pronged approach to try to get people feeling better. So this patient, we will show you what happened with the chemotherapy, but just a little bit more about his history. We found out that he had Jewish ancestry and had a family history of breast cancer in his mother, and also a male relative with breast cancer as well, which is really highly suspicious for a cancer predisposition syndrome, specifically BRCA, BRCA. So BRCA is a famous cancer-related gene, which is normally associated with breast cancer and ovarian cancer, but now we're seeing, because we're doing testing more frequently, we're seeing a lot more patients with the BRCA mutation associated with pancreatic cancer, and Dr. Sussman is going to talk a little bit more about that. And we also tested his tumor. So the testing that we found the BRCA mutation was actually a saliva test. So we're testing the patient, but the testing on the tumor is different, and that sometimes can give us genetic abnormalities that that can help us with the treatment. And the PanCan organization has really pioneered this with the Know Your Tumor program, and we already have data which was presented at a national meeting a few months ago showing the value of doing this type of testing in patients. And there's some cases where specific mutations were found, and they made a big difference. We call those home run type mutations, where you find something and you get a good treatment for it, and it can make the difference between a very poor outcome and a very good outcome. So this patient has metastatic pancreatic cancer. He has a BRCA mutation, and we talked to him about FOLFIRINOX. So even though chemotherapy is not very attractive and we're still using relatively old drugs, this is the best treatment option that we have. And all the patients that we have who are long-term survivors of pancreatic cancer, I would say all of them that in my practice have passed through chemotherapy. And the ones who are the longest survivors have gotten a lot of chemotherapy. So this is what is associated with the most improvement in survival. So with the chemotherapy, it's pain improved, appetite improved, energy improved. And with just a few cycles of chemotherapy, these green arrows are the chemotherapy cycles, we see a significant decrease in the CA19-9 level. And in fact, this patient had the next cycle of chemotherapy was given today, and the CA19-9 level came down to 60 from a high of 10,000 before the start of treatment. So after 6 cycles, this is almost a 99% decrease in his tumor marker level. Now, this doesn't happen to every single patient. So, I'll explain to you why I think this happened specifically for this patient. But this is a CT scan after 6 cycles, showing a significant improvement. You can see the spots in the liver. Some of them have disappeared. The rest of them have decreased. And the mass in the pancreas has also decreased in size. So a question that we get very commonly is, what is the best treatment for me in terms of chemotherapy? So we have 2 standard options that we can use up front, FOLFIRINOX and gemcitabine Abraxane. I'm not going to go through all these in detail, but the schedule is a little bit different. The side effects are a little bit different. In general, we recommend FOLFIRINOX to patients who are a little bit younger, maybe have less medical problems. It's very difficult to tolerate this if you're older and you have a lot of other medical problems. But this is a valid option in most patients. So is there a way that we can select patients better apart from looking at their age and their other medical problems? Well, more recently we have found that patients who have the BRCA mutation or mutations similar to BRCA may have more benefit from FOLFIRINOX, because there's a drug in FOLFIRINOX which is oxaliplatinum. That platinum drug appears to work very well on the deficiency caused by the BRCA mutation. And this is not completely validated yet, but a lot of data pointing in the same direction, suggesting that if a patient has a BRCA mutation, or if you have a very strong family history and you don't even know if they have a BRCA mutation, because when we started this chemotherapy on this patient, we didn't know, or we hadn't confirmed yet that he had a BRCA mutation. But if we suspect that, we usually lean towards the FOLFIRINOX first rather than the Abraxane gemcitabine. And this might be the first time we can really use something called a biomarker to select patients for one treatment versus the other. Now, apart from these 2 standard options, we strongly endorse participation in clinical trials. And PanCan has really done a lot of work in this area to spread knowledge and to raise awareness about clinical trials and promote clinical trial participation and even fund clinical trials. And there's a program which is being developed right now called Precision Promise to bring innovative clinical trials to Pancreas patients across the country. So a very common misconception about clinical trials is that people will get a placebo. This is not true. You would get at least the standard of care, and sometimes you add additional new medications on top of the standard of care. So for example, right now there's a study which is looking at FOLFIRINOX plus an additional medication that looks like it may be beneficial. There are many studies looking at gemcitabine and Abraxane plus an additional medication. And the clinical trials have potential for benefiting not only the patients, but obviously to increase knowledge and to move the field forward. And this is the only way that we'll be able to achieve the goal of doubling survival by 2020 if we really look and seek out clinical trials. And there are many clinical trials available across the country right now, and PanCan, as I said, is a great resource to help you decide if a trial is right for you. So now we're going to switch gears again to go on to screening. I'm going to hand it over to Ben.
So we heard earlier from Dr. Merchant that it's still unclear exactly what are the causes of pancreas cancer. But we're starting to recognize that there's some portion of individuals who have pancreas cancer that have it not just from some environmental risk, but also due to some gene-mediated risk. So who exactly should have germline genetic testing? So just to set some points straight here, there's two types of genetic testing that can frequently happen for individuals with pancreas cancer. One type is the testing of the tumor itself. So the tumors themselves can have multiple gene abnormalities, and that helps guide oncologists like Dr. Hosein in their potential chemotherapeutic management. But there's also genetic testing looking to see if an individual was born with an abnormality affecting all the cells in their body that might increase risk for future cancers. 2 years ago, if we had been discussing who should have germline genetic testing, it would be people who had a very young age at a diagnosis of pancreas cancer, so that would be somebody under the age of 50, or if there were a very strong family history of pancreas cancer, meaning that there were 2 or more relatives with pancreas cancer, including more than one first-degree relative. But over the course of the past couple of years, we now have recommendations from the National Comprehensive Cancer Network, which is one of the national societies whose rules we follow when managing cancer patients, that all patients with pancreas cancer should be considered to have germline genetic testing after they've had appropriate counseling with regards to the implications of the genetic testing itself. Now, this recommendation was made because there's a relatively high number of gene abnormalities that are found in patients with pancreas cancer, but the clinical value of this genetic testing for all individuals with pancreas cancer is still being determined. How does genetic testing happen? Well, after sitting down with somebody interested in genetic testing and discussing family history and potential implications for the result of a genetic test, either a saliva sample or a blood sample is obtained and sent to a laboratory where a large panel of genes is looked at to see if there's a particular gene that may contribute to pancreas cancer in an individual. The genetic test result that comes back needs to be interpreted in the appropriate clinical setting to avoid undue anxiety for patients and to make sure they have appropriate counseling with the implications of these tests for them and their families. So what are the potential results that may come from genetic testing? It turns out that just under about 10% of individuals with pancreas cancer will be found to have a gene abnormality that they were born with that increased risk for pancreas cancer. In other words, the majority of individuals who undergo this germline genetic testing will have normal test results, but somewhere around 10% will probably be found to have a gene abnormality. Without going into the details of each of these gene abnormalities, just to let you know, the most common gene abnormalities that are identified are abnormalities in the BRCA genes or in another gene known as ATM. Families where these gene abnormalities are found typically have other cancer types and relatives, including breast cancers, ovarian cancers, prostate cancers, and melanomas. Some of these gene abnormalities that can be found can be clues to gene problems that can increase cancers in other portions of the gastrointestinal tract, like the stomach and colon. and some of the other gene abnormalities can be associated with inherited pancreatitis, where people have multiple episodes of inflammation of their pancreas over time that can contribute to pancreas cancer. So moving on from the genetic testing for pancreas cancer, which is now indicated for all individuals with pancreas cancer after appropriate counseling, now we can talk a little bit about who's a candidate for screening of the pancreas itself. So some individuals who are found to be born with one of these gene abnormalities, increasing risk for cancer, are candidates for screening. This is certainly the case for the BRCA2 gene, as well as another gene that contributes to a disorder known as Poitiers syndrome. What you see on the bottom of the slide here is some complicated cluster of recommendations for who exactly is a candidate for pancreas screening. I'll let you read through the details of these on your own, but the gist of it is that if somebody has a gene abnormality that they were born with and has a first-degree relative with pancreas cancer, in general, individuals are candidates for pancreas screening, and they're also candidates for pancreas screening if there's multiple relatives in a family who have a history of pancreas cancer. This screening will typically begin at the age of 50 or 5 to 10 years younger than the youngest individual in the family with pancreas cancer, though there's some exceptions based on particular genes. So how is it that we screen the pancreas? We have three potential modalities that can be used to screen the pancreas. The first of them is the endoscopic ultrasound, or EUS procedure, that you heard referred to earlier in this talk. Previously, we heard that it was used to stage pancreas cancers and potentially take biopsies of pancreas tumors, but it can also be used to just look at the pancreas very closely to look to see if there's any precancerous growth within the pancreas, including cysts, which are collections of fluid, or solid abnormalities, which may be tumors themselves. We also heard a little bit about CT scans of the pancreas, and so CT scans performed with a pancreas protocol, so that has IV contrast or intravenous contrast, can be used to look at the pancreas. One of the drawbacks of this modality is that there's radiation involved, and if an individual is going to have multiple imaging studies over the course of their life, we want to avoid giving them too much radiation. Finally, MRI or MRCP is a good way to image the pancreas as well. This is another study that's performed with contrast, but this method is preferable because there's no radiation associated with having MRIs over time. And so some combination of these three modalities of endoscopic ultrasound, MRIs, and perhaps even CT scan may be useful in screening the pancreas. In general, when we do decide to screen somebody's pancreas, we'll do it annually, beginning around the age of 50. What I'd like to tell you about now is what are some of the early results of this screening of the pancreas. What you see here is early evidence of the success of screening for the pancreas in those who are previously unaffected with pancreatic abnormalities. This is a study that performed a baseline endoscopic ultrasound and followed up endoscopic ultrasounds, MRIs, or CT scans on annual bases depending on the findings on the baseline study. 16-year follow-up found that there were, in fact, pancreas tumors identified. The overwhelming majority of those tumors were resectable. Our goal when we're finding abnormalities on screening is to find something that's surgically removable so that we can have the patient go on to have longevity, and that when these tumors were removed, the overwhelming majority of these patients also survived for a period at least 3 years and on an ongoing basis as these trials are still ongoing. So this is a demonstration of some early success with pancreas screening. I do want to caution, though, that if pancreas screening is undertaken, it needs to be undertaken at a center that has expertise, meaning they have radiologists, GI doctors, surgeons, and oncologists that are skilled in interpreting these test results so that patients can have appropriate management over time.
So thanks, Dan. We're going to stop there, and I hope we were able to convince you that a multidisciplinary approach to any stage of pancreatic cancer really leads to better outcomes. And thanks, Nipun and Dan, and we have a few minutes for questions. I'm going to turn it over back to the moderator from Pancreas.
Thank you for a very informative presentation. We now at this time have time for a few questions. So to start off, How often do specialists on a multidisciplinary team consult with one another?
So that's a very good question, and highlights, the importance of being at a high volume center, because we have dedicated physicians, surgeons, medical oncologists, gastroenterologists, radiation oncologists that focus solely on seeing patients with pancreas cancer, and we work as a team. So any patient that's presented is reviewed by dedicated radiologists. We discuss the plan of the treatment. Many times now, as you heard in the presentation, these patients will get a combination of therapies. They'll need a gastroenterologist for the workup with the ERCP and the EUS. They'll need a surgeon for the surgery. Medical oncology will be involved. So pancreas cancer is not just management by one specialist. It's a team of people, and we, high volume centers, generally have dedicated multidisciplinary teams that communicate constantly to discuss the management of the patient. Many times, the treatment, the chemotherapy is better to be done before the surgery. Sometimes it's better to be done after the surgery. So all these nuances really have an implication of how patients are managed.
Thank you for that. The next question is, if someone needs treatment before surgery, how does one determine if the patient needs radiation along with chemotherapy or versus chemotherapy alone?
So right now the standard is to start with chemotherapy, and there are many centers across the country that use radiation heavily. It's still under investigation. There's some clinical trials which are ongoing right now because there are different ways of giving radiation. Traditionally, people would do conventional radiation, which sometimes could take up to 6 weeks. There's been a shift in many centers now to do shorter courses of radiation and higher doses in a short period of time. So, it really depends on the expertise available at the institution. But definitely, if we start with chemotherapy, we do scans usually every 2 months. And at every point in time, we usually get together as a group to determine if the scan looks like it's moving in the right direction. Sometimes we say more chemotherapy. Sometimes we say, okay, maybe radiation this time. But in general, it's an ongoing reassessment to determine whether the patient is a candidate for surgery. And there's no fixed number of cycles. Sometimes we give 4 months of chemotherapy. Sometimes we even go up to 6 or 8 months of chemotherapy before surgery. And in some occasions we use radiation. But it really depends on the local expertise at the center to determine when that would be incorporated.
Thank you, doctor. The next question is, if a patient was found to have suspicious cells after getting a fine needle aspiration by an endoscopic ultrasound, do you recommend additional tests if there is no mass found on imaging?
So that's a challenging question, but one would generally think that if a biopsy were performed at the endoscopic ultrasound, that there was likely some abnormality already seen within the pancreas that guided that biopsy. If the biopsy were just taken for some reason of random area of the pancreas, then certainly other testing would be needed. That might include repeating an endoscopic ultrasound with an actual core biopsy rather than just looking at an aspiration. So with a core biopsy, you can obtain larger chunks of tissue, for lack of a better word, that gives you some architecture, versus some combination of the 3 types of imaging modalities that we presented previously to try and look a little bit more invasively for some focal abnormality within the pancreas. One would tend to think that if a biopsy were performed, and especially if the endoscopic ultrasound was performed in the first place, that there might be a little bit more to the patient's history there that guided the necessity of those procedures and interventions. If there were some suspicious-looking cells that were on an abnormal-looking area of the pancreas that was biopsied, then certainly that needs to be followed up at a close interval to make sure that there's nothing growing within the pancreas.
Perfect. Thank you for that answer. The next question is, how beneficial do you find molecular profiling to be to the diagnosis and treatment of pancreatic cancer, and what are the benefits?
So molecular profiling is key. That's the reason why we insist on adequate biopsies, because we need enough tissue usually to get next generation sequencing or genetic testing done on these tumors. So the best data that we have on the value of molecular profiling actually comes from the PanCan Know Your Tumor program, and that the experience has been published and presented, and it shows that up to 15% of patients have abnormalities in a system similar to BRCA, which we refer to as DNA damage repair systems, and those patients may benefit from the platinum chemotherapy like FOLFIRINOX and even PARP inhibitors. That's a new class of drug which has been approved for some time now for breast and ovarian cancer, and there's going to be some very exciting data presented in a couple of weeks' time in an oncology national meeting, which is likely to lead to the approval of one of those new medications for pancreas cancer. So that is a molecularly defined subgroup of patients. So in the past, we have never been able to subcategorize patients with pancreatic cancer to say, okay, like breast cancer, if you have estrogen receptor positivity, you get anti-estrogens. We don't have that in pancreas cancer up until now. But now we are routinely recommending both tumor genetic testing or molecular profiling, as well as germline testing that Dr. Sussman described, to really get the complete picture. And there are a number of clinical trials targeting uncommon mutations. You know, there are drugs now approved for patients who have an abnormality called microsatellite instability. Another new medication for mutations called NTRK, NTRK, which is really new. That knowledge didn't exist 2 or 3 years ago, and the only way we know about that is because we are now routinely doing molecular profiling on patients. And sometimes we insist on repeat biopsies if we don't have enough tissue remaining for molecular profiling. And I have some patients who undergo multiple biopsies so that we can get enough tumor for that type of test.
Perfect. Thank you, doctor. The next question is it more common to monitor the effectiveness of chemotherapy using a CT or PET scan?
So it depends on the situation. In patients with localized tumors, the CT scan is more valuable because you really need to know the anatomy of the tumor in relationship to the blood vessels to make decisions on surgery. In some situations, PET scan may be useful if you have an equivocal finding or an uncertain finding on a CT scan. For example, if a patient has localized disease and we're planning for surgery and you see something that looks suspicious in the liver, sometimes a PET scan might help there. But many people with metastatic pancreatic cancer or cancer in other locations can be followed with a PET scan. But in general, most people would use CT scans.
Perfect. Thank you for that. And then at this time, it's our last question, and it's a two-part question. So what are the benefits of receiving care through a multidisciplinary team, and how can an individual find a multidisciplinary team near them?
So the benefits, as we've discussed, is that the management of patients with pancreas cancer is not unidimensional. Discussing the issues related to diagnosis, related to jaundice, related to weight loss, pain control, all of these factors have to be taken into account. And having a team of specialists that's dedicated and specializes in treating patients with pancreatic cancer is very, very important. A lot of the management, as we talked about, has nuances. Not every patient is treated the same way, depending on their various involvement of blood vessels around the tumor or spread to other areas. The management of every patient is very different. And in multidisciplinary team settings, we discuss all of these patients on a regular basis to determine what the best approach for each individual patient will be. And that can vary from patient to patient. And these type of multidisciplinary teams are almost exclusively in centers that are high volume centers, and that's very important when you're being managed as a patient with pancreas cancer to identify these areas. PanCan is a very valuable resource to contact because they have a list of high-volume pancreas centers around the country, and they could be a great resource to identify a center near where one may live.
Great, Doctor. Thank you again for that answer. We would like to thank all three presenters for their presentation. The PowerPoint slides and a recording of this webinar will be available at pancan.org under the Educational Events page. There may be a delay of several days before the information is posted, and your patience is appreciated. Once again, we would like to thank our webinar sponsor, Ipsen, and our scientific and medical affairs industry members, AngioDynamics, Halozyme, Ipsen, Janssen Oncology, TriSalus, and TYME. A survey will pop up once you leave the session today, so please take a moment to share your feedback. If you have questions, please contact Patient Central at 877-2-PANCAN and ask to speak with an associate. This concludes the webinar. Thank you.